Greetings to all my fellow surgeons. Hi, this is Dr. Simanjil Goel, and this is an interesting small pupil case that I'm going to present today to you. So, once you're sitting in your OPD and a case like this comes up to you, there's several questions that rush through your mind about what to do of a case like this, what to tell the patient, what can the patient expect out of you. The pupil is right now fully dilated to around 50% dilation. The cataract is around grade 2. It's not that hard, but the problem is the patient is on medications for prosthetic hypertrophy, so you can expect intraoperative floppy iris as well. And the this is the maximal dilation that the patient is going to have. Even after opening the anterior chamber, you can expect the pupil to come down in the size once you start off with the phaco. And God forbid, unfortunately, if ever you touch the iris with any of your instruments, you are in big trouble. So, what are my steps? What are my go to steps for cases like these? Should I plan an iris expander? Should I plan some Adriatic agents? What do I do? Some surgeons put adrenaline in their irrigating solution, some use hyper osmotic tropicamide with phenylephrine, some surgeons use BHEX rings and whatnot. There are all sorts of things that you can go ahead to keep the procedure safe. A top surgeon once told me that it all depends on the confidence that you have. Some surgeons can even take on 30% dilated pupils without any assistive devices, and some surgeons are uncomfortable with even 80% of the dilation. It all depends on the equipment that you are handling, the tips and tricks that you have up your sleeve, and the technique that you use. Out of all the phaco techniques that you know, I'm a big fan of direct chop as it serves you well in cases like these. You cannot go ahead with the trenching and sculpting. You cannot go ahead with the divide and conquer technique in cases of small pupils. Even a horizontal chop is blind in cases like these. And uh, and yes, the patient has mild degrees of pseudo exfoliation syndrome as well, so you can expect slight degrees of zonular weakness in these cases. And I have made the speed normal, and I have started with the rexes is very important cases like these. You should aim to outrun the size of the pupil. With a lot of experience, you're going to manage a rexis like this, because you don't have to keep the pupil as the stencil to make a rexis, but you should aim for a bigger rexis. The rexis margin should go ahead invisibly underneath the iris plane. So yes, we have done around 5.5 millimeters of rexes, and we have made these side ports and the main port slightly anteriorly to the limbus. This is the golden tip that I'd like to recommend you. It is around 2 mm anterior to the limbus. And yes, we are doing gentle hydration, as entrapped nucleus can even rupture the posterior capsule. Gentle hydration. And I have done some color correction in this video for you guys to appreciate. The person was really old, and he had questionable clarity of the cornea as well. He had moderate degrees of corneal degeneration as well. So I have done a little bit of color correction for you guys to appreciate what's going on in this case. And I was expecting, the pupil has come down to milder degrees after we have started the case. And once the phaco starts up, the pupil will come down to 30% dilation. But yes, you should never lose hopes. You should go ahead with operating such cases. And I have not used any Midriatic drug or any of the assistive devices. I'll straight away go ahead with the phaco chopping. I'll be doing direct vertical chop, and mind you, I keep the tips of both of my instruments in the center. Never, never, ever touch the iris in such cases, because you will be inviting a lot of trouble. Yes, the nucleus is around grade 2, so the chopping won't go as smoothly as I was expecting it to. I have inadequate tip exposure as well. Once I got hold of this video, I noticed I should have exposed my phaco needle a little more than it is in this case, but nevertheless, we are going to have a combo chop, if I may add. This is not a purely vertical chop. I am having some horizontal movement of the tip as well, because the I'm not able to bury my tip adequately in the belly of the nucleus, because I am a little afraid, because I am not able to visualize the posterior capsule because of the color of the nucleus. The fundal glow is not really good in this case, and just like that, some cortical pieces came up, and yes, this was a satisfying chop. One chop that I was confident that I am going to fare well in this exam was this chop, that I grabbed the endonucleus and just cracked it in two pieces. Once I have two heminuclei, the case is going in the right direction. The pupil, as you can see, is around 30% dilated right now, and I decide to put some visco for coating that endothelium and protecting those precious endothelial cells, because the patient is already having a lot of corneal degeneration. We want good visual results for this old man. And yes, the nucleus, I have debulked the nucleus by around 40% right now, and the last 60% of the nucleus is remaining. And at this time, I have decided to zoom in a little bit for you guys to appreciate the nuclear remnants. And my OT assistant is just irrigating the corneal surface, but and yes, so here you go. I have taken a dialer in my left hand voluntarily and consciously because of the poor visibility in this case. It's always better to have a blunt dialer in place of a chopper. A sharp chopper can is not the way I would recommend you guys to. You can go ahead if you're confident handling a chopper in foggy situations like these, but yes, I love to have a blunt dialer in these cases. And this is the endonucleus, the hard part of the nucleus that is gone. Last 20% is remaining, and yes, I am delighted right now, because I can see a good fundal glow. The posterior capsule is intact, and yes, minimal cortical fibers are remaining. These cases teach you a lot, and just fill you up with confidence for further cases in your career. Cases like these make you confident for you to take on any kind of challenging cases in the future. And the patient was delighted. The patient was 6 by 9 on post-operative day 7. He had minimal edema, I would not deny. This is an unedited video, and we put him on hyperosmotic agents and a good steroid dosing, and the patient recovered well. He had 6 by 9. We would be implanting a Johnson & Johnson monofocal IUL in this patient, and the poor man, was rejected by around 2 or 3 surgeons because they were fearful about the possibility of complications in this patient. But nevertheless, yes, we are going to hydroimplant a monofocal IUL. That's all from my side. I hope you like my stuff. This was an interesting and a challenging case. Only 3 tips I would like to recommend: always keep your instruments in the center, go ahead with the cases that you feel confident for, and yes, do not touch that iris is also called as the policeman of the eye. Once you touch, there is a rapid release of prostaglandins, and which will ultimately cause even more decrease in the size of the pupil. And that's all from my side. This is Dr. Simanchal Goyal signing off. Kindly like, share and subscribe my stuff, because it would help my channel grow. And thank you. Have a nice day ahead.